Hello, my collaborators Ken Kilgore, Bobby Yang, and myself are presenting LASIK potential for missed ocular hypertension, comparing LASIK and untreated eye pressure measurement relative to intracameral pressure. Our financial disclosures are those listed, and the study includes no products from any of these companies. LASIK has been shown to have a sustained decrease in IOP following the procedure. PRK and RK have also demonstrated the sustained decrease in IOP. Goldmann applanation tonometry remains the gold standard for measuring IOP and the only modality by which the FDA qualifies all other methods for measuring pressure. Applanation tonometry measures the combined effect of actual pressure, corneal deformation, and tear film adhesion. LASIK and related refractive procedures produce corneal biomechanical changes and stress redistributions, which are thought to be the cause of decreased IOP measurements by reducing the corneal deformation component, which can be visualized by imaging via OCT, shown here in this slide, the stromal buckling which occurs during applanation tonometry. So we set out to quantify the IOP drop following myopic LASIK. This method came about in discussions with the FDA about how to qualify IOP measurement improvements over Goldmann following LASIK. Originally, the FDA wanted a direct comparison to intracameral pressure by cannulating the AC before and after the procedure. This was obviously a non-starter. We compromised on intracameral pressure comparison of fresh cadaver eyes, both with and without LASIK. Then the cadaver comparison was validated by clinically examining the difference in IOP before and after myopic LASIK. We did GAT IOP measurements on 21 normal eyes, cadaveric eyes, and 18 LASIK cadaveric eyes. It took about a 10-month nationwide search to obtain these eyes. And then all eyes were subsequently intracamerally pressurized between 5 and 50 millimeters of mercury. All measurements were done by 2 independent masked observers. Then separately, we used a clinical verification, which we had GAT IOP measured in 58 patients preoperatively and 3 months following LASIK, again by a masked independent observer. In the cadaver results, what we observed is an overall negative bias or error from cadaver intracameral pressure, which was significantly greater in the LASIK eyes. Also, the LASIK intracameral error was increased at higher pressure, which was not seen in normal eyes. Historically, we had run an intracameral IOP comparison to Goldmann on live patients undergoing cataract surgery and found the same negative bias, validating the intracameral cadaver findings. The clinical comparison before and after LASIK indicated a sustained significant IOP drop following LASIK, similar to the cadaver differential between normal and LASIK treated eyes. As a separate PRK was examined and showed a lesser drop in IOP. Furthermore, the clinical study suggested a tendency to increased IOP drop with increasing ablation depth and an increased change in central corneal thickness. The intracameral comparison and clinical validation quantifies the extent of Goldmann IOP reduction following myopic LASIK, which can be extrapolated to other refractive procedures. New IOP measurement modalities need to be assessed to detect ocular hypertension in patients which have undergone corneal refractive procedures. The takeaway is not to miss the boat on these patients. Early diagnosis is key to primary open-angle glaucoma and ocular hypertension, particularly in the young and at-risk LASIK refractive patients. IOP is still the only leading indicator in the diagnosis of primary open-angle glaucoma, decades in advance to retinal nerve fiber layer loss and visual field changes. Thank you.